A substantial number of patients, as we're seeing decades after Roux-en-Y gastric bypass has been the surgery of choice for a long period of time, a substantial number of patients are now suffering from weight regain, and that can be due to a variety of reasons. We think that one of the major causes is probably that the anatomy fails over time. And so the gastrojejunal anastomosis, or that connection between the gastric pouch and the small bowel, dilates. And our studies have shown that dilation of that is a major predictor of weight regain following bypass. However, the surgical revisions of these procedures are often not easy, and they carry a relatively decent morbidity risk. And so we and some of the other centers around the country and around the world have developed techniques for reducing the size of the gastrojejunal anastomosis endoscopically. And so we have hundreds of patients weekly who come in requesting these procedures, scared to undergo a surgical procedure, but recognizing that all of the benefits of their gastric bypass, including reduction in their comorbidities and all of the weight loss that they'd achieved following the procedure, has now started to return. And so we've developed these techniques to basically to repair their gastric bypass endoscopically so that they don't have to undergo the surgical procedure and undergo the risk that incurs with that procedure. I think obesity is a major problem worldwide, and not only obesity, but the fact that it leads to diabetes and hypertension and cardiovascular disease. And I think with the newer innovation of endoscopic techniques, we're able to basically treat the cohort of patients who have undergone gastric bypass and regained weight. And we also have a slew of primary procedures that we're performing on patients who have never had bypass surgery. And so we are hopeful, based on the results that we have to date, that the excess weight loss will be achieved and sustained for periods of time. And patients will not have to undergo the surgical morbidity that occurs with the revisions. We have several presentations and posters at this meeting on a variety of different techniques that we're investigating and also comparing at this point, because these are relatively new, probably over the last 10 years that these have been available. And more centers are starting to adapt and take on and create bariatric centers and really help manage obesity, which is such a major problem worldwide. We're interested in comparing different types of endoscopic suturing. For this particular study, as I mentioned, we used what's called a purse string technique, where we place sutures in a circumferential pattern around the gastrojejunal anastomosis and secure it over a balloon. Other groups and our group as well, have dabbled with interrupted sutures as opposed to just a single purse string suture. We're putting interrupted sutures around the outlet. And our work from this meeting as well shows that we think a purse string probably has more durability, despite being slightly harder to do endoscopically. We think that it's probably a better approach. We use a variety of different devices. We use another device that creates tissue plications within both the gastric pouch and the gastrojejunal anastomosis to reduce the outlet size. And so we have several studies looking and comparing that to other techniques, including endoscopic suturing, including argon plasma coagulation. And we also our center has developed a variety of different more novel ways of approaching obesity, including the development of magnets to create de novo anastomoses, surgical anastomoses, but doing so endoscopically. We also have a variety of different therapies for endoscopic treatment of obesity that are now available worldwide, including gastric balloons and other forms of endoscopic devices to promote weight loss. So I think this is a very exciting and growing field, and there's certainly a lot of interest here that we've seen, and I think it's moving forward and helping a lot of people. The most exciting wave of all of this is that now that a lot of these devices have been used and trialed, and we're getting really good results, and our group just published our 3-year data on endoscopic suturing. I think it's exciting to think now moving forward about combining some of these modalities. So using both, endoscopic suturing in addition to, some sort of small bowel procedure, or an intragastric balloon and a small bowel procedure. And I think that is going to be sort of the wave of the coming years.